Good day, my name is Mac Auliffe, and today I'll present a study carried out by our team in collaboration with the University of Geneva called brain computer interface-driven neuromuscular electrical stimulation therapy for motor recovery of subacute stroke patients. This is the first of a two-part study, and the second part will be presented tomorrow by my colleague or one faculty. Nowadays, the impact of physical therapy on highly impaired post-stroke patients remains limited due to a lack of cortical spinal tract integrity and a high local disruption of functional connectivity between the damaged and other brain areas. We hypothesize that neuromuscular electrical stimulation, or NMES, contingent to voluntary activation of the primary motor cortex, as detected by a BCI, can help restore cortical spinal projections and feedback into the ipsilateral sensory cortex to reactivate components involved in motor control, impacting on recovery. Here we report preliminary data from an ongoing clinical trial with subacute stroke patients with a high motor impairment on one of their upper limbs. First, we assess the integrity of structures and functions with clinical evaluations. Additionally, we use high-density EEG to assess the result of the treatment. Both were conducted during the first and fifth week with some additional clinical evaluations 3 months after stroke. Then at the beginning of the second week, we used a 16-channel EEG and a type of NMES called FES to build individual PCI classifiers able to differentiate movement attempts, either flexion or extension versus rest. Then between the second and fourth week, patients were divided between a BCI group with 10 patients and a sham group with 8 patients. Both groups completed 10 sessions, but only those in the BCI group had their respective classifier integrating neural attempt probabilities with the FES delivering a trigger. During the first week, fifth week, and follow-up, we ran statistical analysis on clinical evaluations. For the modified Ashworth scale, we found significant differences when comparing scores between the fifth and first week, showing that the sham group presents a significantly higher score than the BCI group, meaning a higher spasticity by the end of the fifth week on the plot on the left that is finally lost during the follow-up on the right. For the functional independence measure, we found significant differences between the follow-up and the first week, showing that the BCI group presents a significantly higher score than the sham group, meaning a lower motor disability on the follow-up. Between the second and fourth week, we calculated the percentage of accuracy of cortical activity and FES triggers for BCI and sham groups, finding a significant difference between functional move and rest. Then we calculated the correlation between accuracy and motor improvement measured by delta FMA, showing an increment from sham towards the BCI cluster. In conclusion, we observed that a BCI FES treatment tends to improve motor impairment on highly impaired post-stroke patients. However, these results are not yet categorical nor sustained over time, which could change as the number of patients increases. We also observed that patients in the BCI group benefited from using their own classifier, facilitating the accumulation of evidence in favor of motor triggers. This in turn will affect proprioceptive and somatosensory activity, increasing cortical excitability and neuroplasticity. Thank you.